Sitaram is there, video on, audio on.
Hello,
Actually, Sitaram is just in COVID duty. But he volunteered to be a part of this interaction.
Oh, great, great.
And who from where these two residents are?
The one is our student, Sitaram is our Manipal, sir. And second one is from Hyderabad, sir.
Rajesh? Rajesh, can you unmute yourself? Yeah.
Video on.
Rajesh, can you unmute and switch on the video? Yeah. Just introduce yourself. You're muted. Your audio is muted. Oh, yeah.
Good evening, sir. I am Dr. Rajesh from Yashoda Hospital, Hyderabad.
Good evening, Rajesh.
Welcome.
Yes, sir.
Another 5 minutes to go.
So Rajesh and Sitaram both are on duty at present.
Sir, these are COVID duty, sir.
Tell me, Surya.
They're doing COVID duty, sir.
Yeah. We had a lot of COVID patients. So he's in ICU actually. We have 3 residents every week are being given to this medicine for doing COVID duties.
But how is your work, sir? Urology work is picking up?
Yeah, it's picking up. But still people are scared to come to the hospital thinking that ours is a COVID hospital. But I think from January onward, it will become a little better.
Okay.
Transplant attendance is increasing.
Okay.
OPD attendance is increasing now.
Increasing. Okay. You have started transplant, sir? Transplant?
No, not yet.
Okay.
Because we don't have that foolproof arrangement of attendance and other something like what you can say a bubble, where we can have no entry to attendance party and they remain COVID free. Because we have around 300 patients of COVID in our hospital.
Oh my God. Okay. This is circulated only to postgraduate, sir? This
is circulated only to postgraduate. Yeah.
Okay.
And Dr. Rajiv?
Yeah.
Yeah, I think when we are sending the flyer, we can send it to the USI mail also. If some faculty also wants to join, he can join like resident, sir.
Yeah. We will tell Navneet to send to everyone.
Because when knowledge is being disseminated, it's better everybody who wants to
utilize. You are right. We have the concept of TOT also, training of trainers.
Yes.
So they can become our future faculty if they know that what is the format.
Yes, absolutely. And trust me, sir, in every class there is something new to learn.
Yeah, that is. You are the best student, Arun.
He is always inspiring.
Yeah, he is always.
We will remain a student the whole of our life. That's why we are a student of urology. We will remain in life like this only, sir.
But you are always throughout attentive.
Yes.
So now it is already 59. Countdown can start anytime.
1 minute, sir. You have to. 1 minute, sir. 7:59. Navneet, countdown can be given, Navneet?
Yes, sir. Okay, sir. So 5, 4, 3, 2, 1, all yours.
Thank you.
Okay, good evening and warm welcome to everybody for today's smart learning class on adrenal cancer. Before we start, I'll invite the Chairman, Indian School of Urology, USI, Dr. V Surya, for his opening remarks as well as the inauguration of this class. Over to you, sir.
Thank you, Dr. Arun. This is the great time today. In the evening of 20th October today, we have eminent faculty, Professor Surya Prakash, and he will be today having interaction with the two PGs, Dr. Sitaram and Dr. Rajesh from Manipal and from Hyderabad Yashoda Hospital. And this case scenario which is going to be presented and the teaching through that is the theme which we are now adopting in all the classes, and this is becoming very, very successful. And with that theme only, we will start our session today. Dr. Surya Prakash will be presenting a case scenario. Two PGs will be interacting, and there are expected questions on chat. And Dr. Surya Prakash will be then taking at the end the questions on that chat also. And with this, as I have told, I have been telling recently that now the whole teaching is getting converted into competency-based teaching, and this is the new scenario which has been this year adopted by MBBS classes for MBBS classes, and also now it has been, I was the member in the internship training also. This competency-based training is going to be integrated, and the whole format is ready because of the COVID. It got delayed, slightly delayed. And after that is coming for PG classes and also postdoctoral or super specialty classes. So what is the competency-based teaching? This is the format which was conceived and by Euromet programs of Indian School of Urology already. And in this, we have 5 competencies are knowledge. Knowledge is from books, from lectures, and from other sources, or maybe demonstrate or interactive sessions also. And after that, there is know-how. So this knowledge is how about that. The next competency comes know-how, and after that is show. So for that, our other webinars are coming, and I hope all postgraduates are attending that. And after showing is that show how in that our Euromet programs, our simulations, our wet labs, our cadaveric labs, these all are quite handy. And after that is performance. And performance is supervised, and performance is done also when in the next stage. And this is the 5 competency level, and we are following that.
Sir is muted, sir.
You are muted, sir.
You are muted, sir.
Now it is all right?
Yes, we can hear you.
Okay. So I don't know when I got muted, but one thing is clear that this session, interactive session on adrenal carcinoma, is going to be very fruitful, because this is really important for if we are not getting many patients in our clinical practice, but for the theory, for the practical, when we face certain situations and certain patients, this is a very important case scenario. And also uro-oncology is picking up a lot. Many urologists are now getting interested into that, and Dr. Surya Prakash presentations, interactions, and after that at the end he will conclude his talk, is going to be really beneficial for our student and resident community. All the faculty like us are also going to be benefited. So stay tuned and prepare your questions for interactions in the chat also. And it is handed over to, I declare it open and inaugurated, and I hand it over back to Dr. Arun Chawla to invite Dr. Surya Prakash.
Thank you, sir. Thank you very much. Let me introduce Dr. Surya Prakash to all the residents. He doesn't need a formal introduction, actually. Dr. Surya Prakash is at present a consultant urologist at the Yashoda Hospital. But before that, he has been a faculty in various positions at Nizam's and has been professor and head at Narayana Medical College, Nellore. And interesting thing about him is he's a very versatile. He is not only from range from open surgery to lap and robotics. In every type of surgery, he is very well skilled, and he is perfectly backed by his very deep knowledge on every subject of every subspecialty of urology. I think you will all be very benefited by today's presentation of adrenal cancer. And without wasting much time, I invite Dr. Surya Prakash to start his presentation. Over to you, sir.
Thank you, sir. Thank you, Arun Chawla, sir, for the kind introduction and for giving me this opportunity. I also thank Rajiv Sood, sir, for inviting me on behalf of USI and Indian School of Urology. I really appreciate and congratulate you for this wonderful, innovative program. And I'm sure this is going to benefit all our postgraduates to improve their knowledge. Today's topic, without wasting time, I'll go to the topic. Today's topic given to me is adrenal cancer. Though the incidence of adrenal cancer is less, it's a very important topic for all of you. As sir said, not only for your clinics, but also in theory. This can be asked as a theory question, 10 marks question. It can be asked as a specimen. It can be asked in a C-tip in your viva. And of course, if any lump abdomen come, it can come in the differential diagnosis. So what I'm going to do is, I'm going to show you a clinical case. And of course, we have Dr. Sitaram from KMC Manipal, a urology postgraduate, and Dr. Rajesh from Yashoda Hospital, Hyderabad, urology postgraduate. They'll be interacting with me in the case discussion. Are you able to see my screen?
Yes, sir. Yes.
Surya Prakash, but I think this presentation is optimized for video. It is showing some. Come to the next slide. Come to the next slide. Yeah. Okay, but yeah, it is a little dull actually.
I click that optimize video. Shall I?
So you have to. You have video? Any video?
No.
That means you better come without a video because it's looking like a video presentation. That's why it is like this.
Okay. Yeah. Yes. So, yes.
Slideshow? Yes.
So today's webinars or learning objectives we'll be discussing about the clinical presentation of adrenal tumors, in particular adrenal carcinoma, how to image and how to evaluate them for function of these tumors. Is there any role of biopsy? How to arrive at the diagnosis? What are all the differential diagnoses? Role of histopathology, how to stage these tumors, how to treat them, and after treating, how to follow this. So I will be discussing, focusing on these headings. So now, Dr. Sitaram and Dr. Rajesh, I'll be presenting, this is a real case scenario, which I operated in the year 2014. He's a 53-year-old male patient who presented to us with the following complaints. I'll give you this history. If you want anything extra, you stop and ask me. I'll tell you the relevant history. So his main complaint was low-grade fever on and off for 15 days. And he could feel some mass in the abdomen for the past 10 days. There was no history of pain abdomen, no LUTs, no hematuria, no GI symptoms. And he was non-hypertensive, non-diabetic, no past history of CV or CAD. There is only one past, maybe non-relevant surgical history, underwent a left hydrocele surgery. He was not on any medication and no prior history of any urological interventions. So Sitaram and Rajesh, this is the history. Do you want anything else? Or shall I go ahead?
Is there any history of loss of weight, loss of appetite?
No, there is no history of loss of weight, loss of appetite.
Any cough, SOB?
No, there's no history of. So
smoke? Any history of Smoking, alcohol.
No, there's no history of smoking. Why do you ask for loss of weight, loss of appetite, cough and
It's,
all?
I'm suspecting any malignancy
Exactly.
because there is a
The
mass.
patient could feel a mass in the abdomen. So whenever there's a mass in the abdomen, when you think of malignancy, you should ask for the systemic symptoms. So intentionally, I did not put certain symptoms. So you should also ask for these symptoms caused by the mass and symptoms which may be caused by the mass which has spread, like symptoms due to metastasis.
Any history of stone disease?
No, no history of stone disease. Okay. So coming to the examination, he was moderately built and nourished. His blood pressure was 130 by 80 millimeters of mercury, and pulse rate was 90 per minute. Other system examination was normal. Coming to abdomen, abdomen was soft, but there was a 15 into 10 centimeter mass palpable in the left hypochondriac, lumbar, and also extending into the umbilical regions. The mass was firm to hard, non-tender, except for the upper border or the other borders were clearly felt. The mass was moving with respiration and it was bimanually palpable. There was no free fluid in the abdomen. External genitalia were normal and the DRE was normal. Okay?
Okay.
Yes. Any lymph nodes?
Where do you want?
Supraclavicular.
There are no supraclavicular lymph nodes.
Sir, he's a male patient, right, sir?
Yes.
Varicocele or anything, and lower limbs, any edema was there, sir?
No. So why
No,
you want to look for varicocele and lower limb edema?
So the patient as of now, one divisional diagnosis, I'm having a malignancy, and I am suspecting as it is in the hypochondriac and lumbar region. If it is of renal origin, there can be associated with varicocele, and any mass lesion in the hypochondriac lumbar region can be involving the IVC, and it can also have lower limb edema. So just to know regarding that, I asked for those two conditions, sir.
Okay, so if the left-sided mass varicocele present, what do you suspect? Where is the
IVC, sir? Renal vein.
Renal vein.
Renal
so if
vein,
it was a right-sided mass, then it has to be IVC thrombus.
IVC.
Because the gonadal vein drains into the IVC on the right side.
Yes.
Okay. This should you keep in mind. So this is the examination findings. So I'll give you, before we go to the differential diagnosis, these are the basic investigations. His complete urine examination was like this, normal, and complete blood picture also. Hemoglobin was 12.3 grams, total count was 10,200, differential count was normal, ESR was high, platelets were normal, coagulation profile was also normal, O positive blood group, blood sugar is 90 milligrams percent, renal functions are normal, one creatinine, and is also normal. So what do you want next?
In the blood test, additionally, I would have calcium if available, sir, because I am suspecting RCC. And after this, I will like to have an imaging modality, sir. If ultrasound is readily available, like an extension of clinical examination, I can go with ultrasound. If ultrasound is not available, then I would like to go with a contrast enhanced CT, as creat is normal. I will prefer CECT, sir.
You cannot frame your answer like that. Ultrasound is not available. Ultrasound will be available before a CT because
ultrasound, sir. I'll go with ultrasound, sir.
You ask for an ultrasound. So ultrasound showed large mixed echogenic mass occupying the left hypochondrium. It is present between the left kidney and the spleen, and they have opined it as a probable retroperitoneal mass. The other kidney was normal. The right kidney was normal.
Okay, sir. Size anything was mentioned, sir? Size anything was mentioned?
Size about almost 15 into 10 centimeters. Large mass, they say.
And regarding any comment was there about renal vein and artery, sir? Any comment?
They could not. This is what given in the ultrasound.
Okay. Then I would like to have a CECT, sir. Abdomen pelvis CECT.
CECT abdomen. Okay. So this is the plain CT.
Okay.
Are you able to see the images?
Yes, sir. Yes.
Just go through the plane and then I'll show you the contrast images. Can you comment on the plain images? Yeah. Just focus on the left side.
Sir, actually, voice is breaking, sir. I'm not able to hear.
Your voice is clear. I can hear your voice.
Sir, in the plain CT images that were provided, there is around approximately probably a 10 into 15 centimeters lesion
Size you
with
cannot
altered
mention.
echo. Yes, sorry, sir.
Size is not mentioned. No, you cannot.
Not mentioned, sir. Not mentioned, sir. Looks like, sir. Looks to me. Just
see the contrast image.
Yes, sir.
Sir, your voice is breaking, sir. We are not able to hear you.
What about Sitaram? You are able to hear my voice?
Yes, sir. I'm able to hear, sir.
Maybe problem from your side, Rajesh. Okay, can you
video, sir. Maybe connection is the problem.
Your voice is again breaking. Now we can't hear your voice.
Sir, there is a lesion. Yes, sir.
Yeah.
There is a lesion with altered echogenicity with necrotic, probably a necrotic material involving.
No, you can't use the word echogenicity when you're reading a CT.
Yes, sorry, sir. Yes, sir.
There is a mixed density mass lesion.
Mass lesion. Yes, mixed density mass lesion. Noted. Looks probably arising from the left upper pole of the kidney or from the adrenal, sir. I am not very sure in the cut section. From the adrenal or upper pole of the kidney, and
yeah. So you're right. We are not very sure based on the CT images whether it is arising from the upper pole or from the adrenal or from the retroperitoneal structures. It's a fairly large mass, mixed density mass. There are some areas of hypodense areas, probably necrotic or cystic areas, and the mass looks a little vascular in the periphery. And can you comment on the vasculation? I think aorta, it is seen even it is pushing the aorta to one side. I'll show you the report. Yes. The report is like this. It's a large, well-defined retroperitoneal solid lesion of Hounsfield 37 to 39 Hounsfield units with multiple hypodense necrotic areas with small calcific foci, predominant in the left hypochondrium, extension into epigastric, umbilical, and left lumbar regions. It is seen extending inferiorly into the upper pole of the right kidney, causing marked indentation on it. Superiorly, the lesion is seen in the hypochondrial region, indenting and displacing the spleen upwards and laterally. Medially, the lesion is seen indenting and displacing the abdominal aorta to the right. Laterally, it is extending to the lateral abdominal wall muscles. On contrast administration, lesion shows marked contrast enhancement after 60 seconds with numerous blood vessels traversing through it. So the impression is a well-defined, solid, enhancing retroperitoneal lesion with multiple necrotic areas, few calcific foci, receiving blood supply from the renal artery and draining into renal vein in the left adrenal region, causing mass effect and displacement as described above, a possibly adrenal tumor. Okay?
Yes, sir.
So now, before we go to further investigations, can you tell me the differential diagnosis?
Sir, from the clinical picture and looking at the CT findings, that too especially the Hounsfield units that they have mentioned with initial Hounsfield units and the post-washout Hounsfield units, my first differential diagnosis will be an adrenal lesion, sir. Mass arising from the adrenal gland, probably the adrenal carcinoma, malignant lesion of adrenal will be first differential diagnosis.
No. How come your Hounsfield unit is helping you to arrive at the diagnosis of adrenal malignancy?
Sir, in a diagnosis of malignancy and imaging, the characters we look for is one is size, one is the appearance on a plain CT image, the irregularities of the border, the density of the.
You said specifically about Hounsfield units. Based on Hounsfield units, I am considering adrenal malignancy.
Okay, sir. Like all those factors I have considered, sir. Size is more, and the next one is Hounsfield units. In plain, it was 37 to 39 Hounsfield units, and adrenal malignancy average Hounsfield units is 39 Hounsfield units, and post contrast, generally the Hounsfield delayed, there will be a delay, the delayed washout will be less, sir. That will be less than 60 Hounsfield units, sir. So
but what about renal malignancy? Will it be different, the Hounsfield units, or the same like this?
Renal is I'm
the same plain CT,
yes,
it will have a soft tissue density and it will enhance with contrast.
Okay, yes, sir.
Hounsfield units will help you in arriving at a diagnosis of adrenal adenoma. If there is a rapid washout, then you can consider it adenoma.
Okay, sir.
Whether it is an adrenal malignancy or a renal malignancy, there will be a soft tissue of 30 to 35 and enhancement. What enhancement you consider significant after giving contrast?
Enhancement of more than 15 to 20.
Yeah. Suppose if it is 30 or 35, it becomes 50, 15, more than 15 Hounsfield units, you consider this significant. Around 10 Hounsfield units, it is equivocal.
Yes.
Okay. So, okay, I'll tell you. I'll put you the differential diagnosis. You tell me the pros and cons. Why it is or why it is not. Renal tumor. Will you consider? Can you switch on the fan?
Yes. I will consider, sir.
What is against renal tumor in this case?
One is post contrast. Delayed phase. The Hounsfield units enhancement was not more than 15, sir.
It was around 50 only.
39 was initially mentioned, and then 45 they told, sir. So
where do you think it is arising from? What is the renal tumor? Upper pole?
Upper pole, sir.
It is a well circumscribed mass. It is a little unusual for such a large mass without involving the kidney. And you can see in the coronal images, the kidney is pushed down.
Pushed down, yes, sir.
So if such a mass definitely will involve the kidney, and pushing down the kidney little unusual in renal malignancies. It will involve the kidney.
Yes.
And what about renal vein and renal artery?
Renal vein and renal artery looked and reported to be normal, sir. They were not involved, so no thrombus was noted.
Yes. Okay. So you can consider there are points in favor or both against renal tumor, but really large tumor and causing indentation. So possibility of being a renal tumor is less, but still you can't rule out. Okay.
Yes.
So second, my differential diagnosis pheochromocytoma. What are points in favor and what are against?
Pheochromocytoma, one is the clinical picture, sir. Starting with the clinical picture, there were no typical symptoms associated with pheochromocytoma. So
what percentage of pheochromocytomas are silent, clinically silent?
Usually 20% of the pheochromocytomas are silent, sir, like no hypertension, no clinical signs and symptoms.
Especially large pheochromocytomas, because whatever the metabolites are released by the tumor or catecholamines released by the tumor or metabolized within the tumor. So very large pheochromocytomas they do not have the classical symptoms like hypertension, palpitation. Only when you do investigations like biochemical investigations, urinary or blood tests for catecholamines and metabolites of catecholamines, then only you diagnose. So that is one point in favor of pheochromocytoma, large pheochromocytoma. And symptoms are not there. That is against. Could it be oncocytoma? Renal or adrenal oncocytoma?
Oncocytoma will be hypervascular with the central scarring.
Central scarring is seen in renal oncocytomas. But in adrenal oncocytomas, they do not have a central scar. And they are mostly solid masses, uniform, homogeneous masses. Here it is a mixed density. You see some areas of hypodense, some areas of soft tissue density. So it's this is unusual about oncocytoma. And oncocytomas can grow very large, like your malignancies. You can even see a tumor which is of 20 centimeters. And are they functional? Do they secrete any hormones? Oncocytomas? They are usually not functional.
Usually not functional.
They are non-functional tumors. So that is about oncocytoma. but still it's a rare possibility because we have not done biochemical evaluation in this patient.
Yes.
So could it be adrenal myelolipoma? What are points against adrenal myelolipoma in this case?
Adrenal myelolipoma, Hounsfield will be less than 10, sir, in CT.
Adrenal myelolipoma is a CT diagnosis. Looking at the picture, you can tell this is adrenal myelolipoma because it is composed of two types of structures. One is lipomatous tissue, mature adipose tissue, and hematopoietic tissues. Hounsfield units will be less than 10. It looks black. And again, these tumors are non-functional tumors. And again, they can go to very large size. Unless symptomatic, we don't usually operate them. If they're very big size causing symptoms, then only we operate them. So the CT picture is not looking like a myelolipoma. We can rule out myelolipoma. Could it be adrenal adenoma?
Adrenal adenoma is also like mainly in CT imaging, sir. Hounsfield units will be less than 10. And,
Correct.
so
Yes.
probably
What you were telling earlier about washout.
yes.
Again, adrenal adenoma are predominantly lipid-containing tumors, and the size goes against adenoma in this patient because they don't
Yes.
are not usually beyond 4 centimeters, less than 4 centimeters, less than 10 Hounsfield units on plain CT. And how does it look on contrast CT adenoma?
More than 60 Hounsfield units will be there with a rapid washout, sir. So
Not more than 60 Hounsfield units, more than 60% washout.
sorry, 60% washout. Yes.
More than 60. That is called absolute washout. And what is relative washout?
It is more than 40, sir. More than equal to 40.
Basically, what do you mean by washout? You have to compare the contrast retention between the plain and the delayed. That is absolute contrast, absolute washout. And when you compare the contrast difference or Hounsfield unit difference between the arterial phase, that is immediately after contrast administration, and delayed, that is a relative washout. So the contrast doesn't stay in the tumor, it gets washed out. So that is in favor of adrenal adenoma. Whereas in malignancies, there will be contrast retention. So that is diagnostic. Almost we can diagnose adrenal adenomas based on CT washout studies. So here again, the tumor is very big and the contrast is retaining in the delayed films. So it goes against adenoma. So could it be neuroblastoma? Where does neuroblastoma arise from?
The primitive neural crystals,
Yeah,
the
from the
location
sympathetic ganglia.
Yes, sir.
Very aggressive tumors. They are basically predominantly seen in pediatric age group. They can be seen in adults, but it is unusual. Very aggressive tumors, very bad prognosis. They are arise from the sympathetic ganglion of the retroperitoneum.
Yes.
Okay, and you don't find the classical symptoms because it is not from the adrenal. There won't be any it's not a functional or hormone secreting tumor. Could it be ganglioneuroma? Again, another tumor which is arises from the nerve sheath cells, arises from the Schwann cells and the nerve sheath cells. It also can grow to a very large size. It again encases the vessels. Again, there is not a functional tumor. If it is symptomatic, then a large size tumor requires resection. Could it be adrenal cyst? Rajesh or Sitaram?
No, sir. CT shows solid like lesion. No cystic changes in the CT.
What are the types of adrenal cysts, you know? There are 4 types of adrenal cysts. They are basically classified into pseudocyst, endothelial cyst, epithelial cyst, and parasitic cyst. Pseudocysts are cysts which are formed because of suppose there is an adrenal hemorrhage, and the hemorrhage gets liquefied after some time, becomes clot and then liquefied. So such adrenal cysts, they mimic, they give an appearance of, you cannot differentiate between malignancy. They still look like a malignant tumors, that mixed density areas. And endothelial cysts or lymphangiomatosis or angiomatosis. Endothelial cysts, glandular cysts or cystadenomas. Again, sometimes it is difficult to differentiate them from malignancy. And parasitic cysts like hydatid cysts are sometimes seen. So large adrenal cysts can mimic malignancy. So cysts with varying density sometimes mimic malignancy. You have to keep them as a differential diagnosis. Could it be adrenal metastasis? So again, the metastases, they don't go to such a large size. And sometimes the metastasis can be bilateral, and there is no past history of any malignancy in this patient. So if the patient has got a previous history of any malignancy, then you can consider adrenal metastasis. No past history of malignancy, and the tumor is very large, so we can rule out adrenal metastasis. What about adenocortical carcinoma? What is in favor? What is against?
The favorable symptoms are adrenal cortical carcinoma need not have any typical symptoms of any adrenal lesion, can present as a local symptoms like as the patient presented mass symptoms. And then on the imaging, CECT is also in favor of a lesion arising from the adrenal and malignant features. So
there are many points in favor of adenocortical carcinoma. So it could be a retroperitoneal sarcoma, retroperitoneal liposarcoma, leiomyosarcoma. Possible, but these are all well-defined lesions, not involving the muscle planes. So you can entertain, but it's a lost possibility. So these are all the possible differential diagnoses when you find any mass lesion in the retroperitoneum. Okay.
Yes.
So now, after seeing the CT, after ruling out most of the differential diagnoses, what I have told, considering adenocortical carcinoma, what would you like to do next?
Considering adrenal cortical carcinoma, I would like to have a functional evaluation of the tumor, sir.
Yeah, correct. What you said is correct. So why do we do functional evaluation? Because the adenocortical carcinoma secretes certain hormones, so they help in diagnosis. And it also helps in post-op cortisol replacement. Suppose you remove the tumor which is secreting corticosteroids, suddenly the patient will be deprived of cortisol, so you have to replace post-op cortisol. And these hormones also act as tumor markers for post-op surveillance. So these are the three reasons why we do hormone evaluation. So what are the hormones which are usually evaluated for? All the three. What are the three layers of the adrenal cortex? What hormones they secrete? Glucocorticoids, mineralocorticoids, sex steroids, and adrenal medulla which secretes catecholamines. So in this patient, so these are the report like. So the dihydroepiandrosterone was elevated. It was 796. The range was 59 to 450. The cortisol was normal. This is overnight low-dose dexamethasone suppression test. Cortisol was within the range. Electrolytes were normal, and the 24 urinary metanephrines were also within normal range. Okay.
Yes.
So, what is your diagnosis now?
It appears to be like adrenal cortical carcinoma with hypersecretion of sex steroids. THEA was elevated.
It is an adrenal tumor because it is secreting dihydroepiandrosterone. You can rule out pheochromocytoma because the urinary 24-hour metanephrines, which is very quite sensitive investigation, which has got a sensitivity of nearly 97%. So if it is negative, means we can rule out pheochromocytoma. Cortisol is normal. So other differential diagnoses like oncocytoma, adrenal cyst, renal tumor have all been excluded. Now we are left with adrenal mass, which is secreting hormones, probably adrenal cortical carcinoma. Why? Because the sex steroids are mainly secreted by carcinomas. So now the diagnosis is adrenocortical carcinoma. What do you think is the stage looking at the CT? So we'll come to the staging when I come to my talk on staging. So this is a stage one.
Stage 2, sir, probably. Stage 2.
Stage 2 is T2, N0, M0. We could not find any lymph nodes. So yes. This is the clinical staging. It's a large tumor, more than 5 centimeters. More than 5 centimeters is T2 is more than 5. CT wise, we could not find any obvious or gross lymph nodes. And there are no distant metastases. Of course, we have not done a identification PET scan and chest X-ray. They are normal. So it's a T2, N0, M0, stage 2 disease. So what do you like to do next? So you need to treat
aesthetic evaluation for the
so you need to operate.
Yes.
Yeah. We need to have a thorough preoperative preparation of this patient. If the blood pressure is high, you have to control the blood pressure. Stress dose cortisol, of course, in this case, the cortisol was normal, so we don't need to give a stress dose cortisol. Cardiopulmonary workup, reserve adequate blood, perioperative antibiotics, and consent for adjacent organ removal. So what is the approach? Would you like to do a laparoscopy, transperitoneal or extraperitoneal? What would be your approach for operating on this patient?
I would prefer to go with an open approach, sir, like open surgical procedure.
Correct, correct. And what would be your incision?
I would go either with
the preferred approach is anterior transabdominal approach.
Lane, sir, or chevron incision.
Yeah, the best exposure will be you get by giving a subcostal or a chevron incision. And you can also give a midline, but better exposure is with a subcostal incision. So this patient was operated, and there's a large mass which was, you can see in the picture, which was displacing the spleen upward, kidney downward, and the vasculature was from the renal vein, adrenal vein was draining into the renal vein, and there was a very big prominent artery which was going to the renal artery. So the open left adrenalectomy was done by a transabdominal transperitoneal approach. So this was the tumor, a fairly large tumor, and this is a cut section of the tumor. And the histopathology was adrenal cortical. I have the detailed report. This is adrenocortical carcinoma, T2, and there were no lymph nodes, so the lymph nodes were not submitted. So coming to discussion on adrenocortical carcinoma, it's a very rare disease. The incidence is very less, 1 to 2 per million. The SEER database shows that it's 0.7 per million per year in the United States. In which age group it is common? It has got bimodal peak, the first decade, and the second peak is in the 4th to 6th decade. They constitute about 1.3% of all childhood cancers, as opposed to 0.02 to 0.2% of adult cancer. So such a rare tumors. Predominantly seen in females with a ratio of 1.5 to 2.5 is to 1. And what is the etiology? There are sporadic tumors and genetically predisposed tumors. So genetic predisposition is one of the important cause. There questionable role of some risk factors. They're not full proven, like smoking and contraceptive pill use in the women. So this is given in one of the articles which was published about on the risk factor for adrenal cancer. The definite role is genetic predisposition. But majority of the tumors are sporadic and majority are unilateral, 2 to 6% are bilateral. So the syndromes which have got genetic predisposition to adrenocortical carcinoma are Lee-Frommeni syndrome, Wiedemann-Beckwith syndrome, Lynch syndrome, Menn syndrome, McCune-Albright syndrome, and Carney complex. So each syndrome has got one gene which is abnormal or defective, which predisposes to a tumor in these patients. You can see all the syndrome, the stable syndromes, and this prevalence of syndrome in adrenocortical carcinoma in patients and prevalence in general population. And what is the gene mutated? So in Lee-Frommeni, it is a P53. In Menn syndrome, it is a menin gene. Lynch syndrome, it is MSH2, MSH6. These are the genes. Wiedemann-Beckwith syndrome, it is IGF2, this is insulin-like growth factor gene. Familial adenomatous polyposis, APC gene. Neurofibromatosis and neurofibromatosis 1 gene. And Carney complex is a gene. So along with this adrenocortical carcinoma, these patients with these syndromes have so many other features, so given in the other phenotypes. So maybe for theory part, you should know about these syndromes and what are the other manifestations of the syndromes. So the P53 malfunction is seen in 20 to 30% of sporadic ACCs, that is adrenocortical carcinomas, and increased IGF expression is seen in 90% of the patients, and the activation of WNT or beta-catenin pathway is seen in nearly 30% of the cases. So having learned about the epidemiology and the genetic causes of adrenocortical carcinoma, now we come to the clinical presentation. So basically these tumors, these cancers, they are present in 3 different ways. So majority, that is 40 to 60% will have some present with some hormone excess, that is symptoms and signs of hormonal excess. 30% present with local growth, like a renal malignancy, they can present with abdominal pain, flank pain, fullness, early satiety, and 20 to 30% are incidentally diagnosed. Renal tumors, paraneoplastic syndromes are seen, but they are very rare. Manifestations like hyperanemic, hyperaldosteronism, polycythemia, leukocytosis are some of the paraneoplastic syndromes. And there is another peculiar entity is seen in these tumors. It is called tumor-associated hypoglycemia. It is IGF-2 mediated. It is called Anderson syndrome if it is seen. So now, as we know that the majority of the cancers present with the secretion of hormones, adrenocortical hormones. So what are the hormones which are commonly secreted? So 50 to almost 80% are functional. Cushing syndrome, that's a secretion of cortisol is the commonest hormone secreted. Cortisol plus androgens, next common type. And androgens alone is seen in 10 to 20%. And feminization, that is because of secretion of estrogen, seen in 6 to 10%. And rarest is the aldosterone. So the least commonly secreted hormone is the aldosterone, that is 2.5 to 5%. So coming to each hormone category, as I said, cortisol is the most commonly secreted hormone. So the patient present with features of Cushing syndrome, hypercortisolism, the typical features of Cushing like round face, moon face, weight gain, muscle weakness, stria, all these things will be seen. Sometimes the very high cortisol levels can cause activation of mineralocorticoid receptor. So this is called glucocorticoid-induced mineralocorticoid receptor activation, and they have the features of aldosteronism like hypertension, fluid retention, hypernatremia, hypokalemia. And suppose you see a patient who is rapidly progressing, the symptoms of Cushing's are rapidly progressing, so you think in the lines of adrenocortical carcinoma rather than Cushing syndrome. So how do you evaluate biochemically in a patient who has got symptoms of Cushing syndrome? First is we have to exclude exogenous glucocorticoid exposure. The patient, suppose who is taking exogenous corticosteroids. Once that is excluded, we perform one of these tests like overnight dexamethasone suppression test, late night salivary cortisol, and 24-hour urinary free cortisol. Basically, the idea is we want to know whether this cortisol which is being secreted is from the ACTH dependent or ACTH independent. ACTH dependent is called Cushing's disease. ACTH independent is from the autonomous secretion from the adrenal cortex. So I hope you know about, I'm not going into the details of DST. Basically, there are two types of DST, low dose and high dose. High dose is not being done. The idea of doing this DST is you give dexamethasone and try to suppress the cortisol secretion, which is dependent on ACTH. So if when you give dexamethasone, there will be feedback inhibition of ACTH. So there will be decrease of cortisol. But if there is the autonomous secretion or if it is ectopic ACTH, it will not be suppressed. So that's how you diagnose over secretion of Cushing syndrome. And 24-hour urinary free cortisol levels are also will be abnormal in Cushing syndrome. So any abnormal result, you work on those lines. Again, next thing is if you find an adrenal tumor, you don't have to do an ACTH. But if you don't find an obvious adrenal tumor, like in this case, we have a large adrenal tumor. That means the pituitary is almost excluded, pituitary role. If you don't find an adrenal tumor, you do an ACTH and to see whether it is a pituitary derived or ectopic ACTH. That's how you evaluate a Cushing's. Second is, as I said, the second commonly secreted hormone is androgens. So when the androgens are secreted in females, they present with virilization features like beard, baldness, hoarseness of voice. But in males, these androgens are converted to estrogens by peripheral aromatization, and they present with feminizing features. They don't do over virilization, but males will present with feminizing features like gynecomastia and testicular atrophy. So this is very important. Whenever you find an adrenal tumor which is secreting androgens, you have to suspect a malignancy until proved otherwise. So androgen or estrogen production in adrenal tumors, regardless of the size, should raise a suspicion of malignant adrenal tumor. So as I said, hypersecretion of aldosterone is very rare, but when it is present, the patient present with hypertension or hypokalemia. Another interesting thing about adrenocortical carcinoma is the steroid hormone synthesis is erratic. It is relatively inefficient. So as we know, the cholesterol synthesis cascade of enzymes and derivatives. So there can be somewhere halt, the stoppage of hormone production. There will be excess of steroid hormone precursors. So you don't see end products of mineralocorticoid, end products of glucocorticoids. So hormone precursors are more like androstenedione, 17-keto steroids. That is the reason why even there is when there is excess of steroid hormone precursor, there won't be a classical manifestations of Cushing syndrome or hyperaldosteronism. The large tumors may have only modestly elevated hormone levels. So after doing all this biochemical evaluation to see for glucocorticoid, mineralocorticoid, or sex hormone excess, once you have come to a reasonable conclusion, then you have to image these patients. Because we have already discussed imaging. Now I'll briefly discuss about the pros and cons of each imaging. Coming to ultrasound. So though it is a suboptimal image for adrenal masses, majority of the adrenal masses are detected on ultrasound. Coming to the side variation, right-sided tumors are better seen because here liver and IVC give a better window compared to left-sided tumors where the pancreas, gastric shadow, and renal shadow, you will not be able to see small tumors on ultrasound. So ultrasound is not a very good modality for imaging adrenal masses. CT is the imaging modality of choice. So when you coming to adrenal carcinoma, the findings which suggest adrenal carcinoma on CT are inhomogeneous mass, like in our case, irregular margins, irregular enhancement of solid components after IV contrast, necrotic areas with cystic degeneration, local invasion, presence of calcification, and as we discussed, attenuation value of more than 10 on unenhanced CT rules out adrenal adenoma. And enhancement washout of less than 50% at 15 minutes again rules out adrenal adenoma. And delayed attenuation of more than 35 Hounsfield units is suspicious of malignancy. So these are the features of adrenal carcinoma and CT. So if the tumor is small, unlike in our case, suppose the tumor is 4 centimeters and plus minus, we are not very sure it is secreting androgens. Is it adrenal adenoma secreting androgens, or is it adrenal carcinoma? Then you do a standard protocol called adrenal CT protocol. Here we do CT 3 times. First is non-contrast CT with 5 mm cuts, and contrast CT immediately after giving contrast. That is 1 minute post-bolus imaging and 15-minute washout imaging. So this CT washout study is a gold standard for diagnosing adrenal adenomas, as seen in the flow chart here. So you do a CT. If it is the mass is showing 10 Hounsfield units or less on CT, it is diagnostic of adenoma. Suppose the mass is more than 10 Hounsfield units on CT, then you do a washout study by giving contrast. And if the contrast washout is more than 60%, it is called absolute washout, and again diagnostic of adenoma. And if the relative washout is more than 40%, again it is diagnostic of adenoma. If it is not, the washout is less than 40% relative and less than 60% absolute washout, adenoma is very unlikely, and you have to consider other possibilities. So coming to size and imaging, is there any relation between the size and the malignancy? The answer is definite yes. The adrenal masses which are less than 4 centimeters, malignancy chance is very less. Only 2% turn out to be carcinomas. And if they are non-functional, you can follow them up by serial imaging. If the mass is more than 6 centimeter, consider malignancy until proven otherwise. The masses which are between 4 and 6 centimeters, you have to follow them very closely because nearly 6% turn out to be malignant. So there's a definite relation between the size and the malignancy. So this is the diagram. You can see as the size of the mass increases, the chance of malignancy also increases. Nearly 50% of the tumors more than 6 centimeters turn out to be malignant. What is the role of MRI? So MRI is almost equivalent to CT, but it has got advantage when you want to visualize vascular structures, the adrenal mass involving the vascular structures. MRI is better compared to CT. So how does an adrenal cancer look on MRI? It is iso-intense on T1 weighted image and it is hyper-intense on T2 weighted. And when we give gadolinium, there's a marked contrast uptake because it's a vascular tumor. And these tumors, like renal tumors, can invade into the vasculature. They can go into the adrenal vein, and from there they can go into the IVC. IVC thrombus is seen. And for adenomas, like in CT washout, MRI, there is a characteristic protocol called chemical shift imaging. So this chemical shift imaging identifies lipid-rich adenomas. If the tumor are not positive for chemical shift imaging, then you can easily rule out adenomas and consider other pathologies like adrenal carcinomas, especially if the tumor are large, invading surrounding structures and invading the blood vessels. Coming to the other next investigation, the PET scan. So PET scan is also a very useful investigation. It helps in distinguishing benign from malignant adrenal tumors with a very high sensitivity and specificity. There was a meta-analysis where they say that the sensitivity is to the tune of 97% and specificity to the tune of 90%. The problem with FDG PET is it cannot distinguish adenocortical carcinoma from adrenal metastasis, lymphomas, or pheochromocytomas. Another important point is when we talk of PET-CT, we usually talk in terms of SUV, that is standard uptake value. So as the SUV increases, the prognosis also becomes bad. That means higher the SUV, bad will be the prognosis for adrenal cortical carcinoma. What the cutoff taken is more than 10 SUV is adrenal cortical carcinoma with a bad prognosis. Not standard PET-CT is the FDG PET, but when we talk about adenocortical carcinoma, we use another tracer called metomidate. This is a substance which specifically binds to adrenal cortex and it inhibits the enzymes like 11-hydroxylase. So it is highly specific for adenocortical tissue. So PET can be done with FDG or IMTO, that is iodometomidate PET scan. So when we do a PET, we see the tumor not only in the adrenal distant metastasis, like suppose the tumor has metastasized to lungs or liver, those lesions can be easily seen with a PET scan. So again, to revise once again, what are the differentiating features between adenocortical carcinoma and adrenal adenoma? Size is one important characteristic. If the necrosis is there, goes in favor of carcinoma. Hemorrhage, calcification goes in favor of carcinoma. CT density, we have already discussed this. Less than 10 Hounsfield units, adenoma. More than 10, carcinoma. Chemical shift MRI and contrast washout are very useful in differentiating carcinoma from adenoma. And SUV on FDG PET. If it is more than 1.45, it goes in favor of carcinoma. Less than 1.45, adenoma. So what is the role of biopsy? Any idea, Sitaram and Rajesh? Suppose biopsy this patient?
No, sir.
Why?
There is high
indicated in the indeterminate lesions and
correct.
Those patients are planned for chemotherapy.
So usually not recommended if you find that it is an operable tumor. Why? Because there is a risk of needle tract seeding, because these are very aggressive tumors. They can go along the needle tract, and suppose if there is a tumor spillage, because the capsule is very thin, if you breach the capsule, the tumor cells can go out and spread into the retroperitoneum. There are only few indications, like as you said, Rajesh, unresectable tumors, when you're not planning to have the tumor not planned for surgery. If you want to give upfront adjuvant therapy, then you need to know the histology. In such indication, you do a biopsy. And in locally advanced metastatic disease, to confirm the diagnosis before giving systemic medical therapy, you do biopsy. These are the only two indications for biopsy. So these are flow chart, not only for carcinoma, for any adrenal mass. What is the role of biopsy? So nicely written, this is from the Campbell. So if the mass can be characterized well by imaging, like for adenoma, CT is almost a definitive diagnosis. Imaging CT wise, if you're very sure, then there's no need for biopsy. If the mass is metabolically active, there is no role for biopsy. Well, the biopsy is going to change your management. If it is not changing your management, anyway you're going to operate, then there is no role for biopsy. This is very important. If you strongly suspect adenocortical carcinoma, then you should not do biopsy. Again, if you weigh the benefit and risk, if the benefit is less than the risk, then you don't do biopsy. The adenocortical carcinomas. So most of these masses are well delineated masses. On the cut section, they look like, as is shown in our case, it was brown orange in color with a well-defined fibrous capsule. And local invasion and distant metastasis are the only clear-cut indicators of malignancy. There is some disturbance from somebody. You can mute. So these are the only different. Looking at the image, you cannot tell whether it is a malignant or benign tumor. Local invasion, distant metastasis are the clear-cut indicators of malignancy. So that is why they have come up with many criteria, like V's criteria is there. This is very important. This can be asked in the exam. These criteria help to differentiate benign from the malignant neoplasm. So in V's criteria, there are 9 pathological features based on tumor structure, cytology, and invasion. These are the 9 features. I think you can memorize, you have to remember them. The 9 features are nuclear grade, mitotic rate, presence of atypical mitosis, presence of cytoplasm with the nuclear cytoplasmic ratio. The lower the cytoplasm, the higher the chance of malignancy. Diffuse architecture of the tumor cells, presence of necrosis, invasion of venous structures, invasion of sinusoidal structures, and invasion of tumor capsules. All these features go in favor of malignancy. So if any particular case has got 3 or more criteria positive, then this suspicion of malignancy is very high. There are other criteria like which were described before Wies described in 1984. There are other criteria called Hooke's criteria which were described in 1979. They have taken into consideration histological and non-histological criteria. Histological criteria like growth pattern, vascular invasion, necrosis, fibrous bands, capsular invasion, mitotic index, pleomorphism, and non-histological criteria like tumor mass more than 100 grams, biochemical parameter like urinary 17 ketosteroids, presence of Cushing syndrome, and weight loss. So based on this, they have taken 3 from histological and 2 from non-histological. If they're present, they call it goes in favor of malignancy. Not only the Wies criteria, grading is also important. The low-grade tumors, high-grade tumors. If the mitosis are less than 20 mitosis per high power field, it goes as low-grade tumor. If there are more than 20 mitosis per high power field, we call it a high-grade tumor. And there are certain histological variants like we have in bladder cancer. In adrenocortical carcinoma also, we have histological variants. There is a variant called oncocytic variant, which mimics oncocytoma, but it's a malignant tumor. And there's a myxoid variant, which secretes abundant extracellular myxoid substance, and sarcomatoid variant. All these histological variants are aggressive tumors of aggressive type of adrenocortical carcinomas. What is the role of immunohistochemistry? Not a great role, because most of the adrenocortical tumors are easily diagnosed on routine hematoxin eosin stains, and they do not require supplemental immunostains to document adrenocortical differentiation. But there are certain markers for adrenocortical differentiation, especially in variants, as I said, some sarcomatoid variant or high-grade tumors. You need to know what is the origin of cell of origin. So the adrenocortical markers are inhibin, calretinin, synaptophysin, and one of the most important factors is steroidogenic factor 1. So this SF1 is specific for adrenal cortex. So if a particular tumor is stains positive for SF1, you can definitely say that it is arising from the adrenal cortex. And cellular proliferation markers like Ki67, the higher the percentage of Ki67 labeling index, the higher is the proliferation, the more is the proliferation of the aggressive tumor. Chromogranin A is positive for adrenal medulla. So any tumor which is chromogranin A positive, you have to think that it is arising from adrenal medulla, not from the adrenal cortex. So having learned about the imaging, biochemical evaluation, and pathology, now we come to the staging system. Basically, there are 2 staging systems which you have to remember for your theory. One is from UICC WHO. It is also called McFarlane classification modified by Sullivan. And the other is NSAT, that is European Network for Study of Adrenal Tumors. There's only slight difference between these 2. So before we go to the stage 1, stage 2, stage 3, we'll see what is the T staging. T1 is less than 5 centimeters. T2 is more than 5. T3 is tumor infiltration to the surrounding tissue. T4 is tumor invading into the adjacent organs. N0 no nodes, N1 positive nodes. The M is same, M0, M1. So among these 2, NSAT is most widely adopted classification. Most of the studies, they take into consideration NSAT when they present their results. So stage 1 is T1, N0, M0, same in both. Stage 2 is same in both, T2, N0, M0. So our patient falls into T2, stage 2 category. Stage 3 is T1 to T2, N1. So in stage 3, N1 comes. And in McFarlane, only N1 is present, whereas in NSAT, T4 is also present in stage 3. There's the difference. So in stage 4, in UICC, T4 and M1 comes in stage 4. So T1 to T4, M1, T3 to T4, N1, any T, N0, M0 comes into stage 4. Whereas in NSAT, only M1 is stage 4. So distant metastasis comes into stage 4 category because T4 is already put into stage 3. This is the difference. So having learned about the staging, now we come to the management of the these tumors. So majority of the tumors, as we see in our case, are advanced on presentation. So the treatment should be multi-pronged. It should be surgery plus adjuvant therapy, either radiation or systemic adjuvant therapy. Suppose the tumor which is localized, the treatment is complete surgical excision because it gives the best chance of cure. For locally advanced tumors, we do en bloc resection of invaded organs. And lesional lymph node dissection is very important because it tells about the prognosis. And venous involvement, if it is there, we have to do either bypass or IVC replacement or even IVC interruption. So coming to surgery. So open surgery with transperitoneal access is a standard treatment for localized and locally advanced tumors. So we have to aim for a R0 resection. That means a complete resection without any residual disease, because R0 resection is a strong predictor for long-term survival. Complete en bloc resection of the tumor, periadrenal flat, and adjacent invaded organs is mandatory to achieve long-term survival. Suppose in our case, suppose the tumor is involving the spleen, then you have to do a splenectomy. If it involves the tail of the pancreas, you have to resect the tail of the pancreas. That only gives long-term survival. And loco-regional lymphadenectomy is recommended, and the extent of lymphadenectomy is not clearly mentioned in any of the studies. And whatever the lymph nodes present at the hilum, renal hilum, or around the adrenal have to be removed lymph nodes. And perioperative hydrocortisone replacement has to be given in patients whose tumor is secreting cortisol. What is the oncological principle? Very important. No-touch technique. Preservation of the intact peritoneum on the anterior surface of adrenal gland is very important. En bloc resection, as I said, with a wide margin of surrounding benign tissue outside the tumor capsule. Preservation of the intact tumor capsule. So all these points are possible only with open surgery if the tumor is very big. So it's not possible with a laparoscopy or even with robotics. The exclusion of the remainder of the peritoneum. So you have to pack the all around the tumor so that even if there is some spillage, the spilled tumor will not go into the other parts of the peritoneal cavity by laparotomy pads or plastic barriers or drapes. So minimize bleeding and fluid spillage into the peritoneal cavity. See, even this goes to such an extent that you have to change the gloves and gowns and instruments after removal of the tumor and prior to closure of the abdomen. So there's utmost importance for the tumor spillage. You should not allow the tumor to spill into the peritoneal cavity. So there are some studies where they have shown the 5-year survival results with complete resection and incomplete resection. You can see when you remove the tumor completely, 5-year survival ranges from 36 to 58%. Whereas the tumor is incompletely resected, 5-year survival is as low as 2 months. So what is the role of laparoscopy and robotics? Only for tumors which are small, less than 6 centimeters, without any evidence of local invasion, and that too only in experienced hands. The literature tells about more of contraindications rather than indications for laparoscopy in adrenal cancer. So when you come to contraindications, we can divide them into relative and absolute. What are the relative contraindications? Tumors, large tumors, relative contraindication, localized adrenocortical carcinoma, morbid obesity, malignant pheochromocytoma. These are about all adrenal tumors, virilizing adrenal tumor, and there are abdominal adhesions, and there's a history of recurrent pyelonephritis because there you expect some adhesions between the tumor and the kidney, and pregnancy. These are relative contraindications. Absolute contraindications are local recurrence of a previously resected adrenal mass. Suppose you have done adrenalectomy, and after a few months you see a recurrence in the bed. So in such case, the absolute contraindication to laparoscopy. Invasive adrenocortical carcinoma with evidence of invasion into the neighboring organs, renal artery, renal vein involvement, again absolute contraindication. Severe cardiopulmonary bypass. So the role of laparoscopy is very limited, only in expert hands, only for small tumors, and only for tumors which are confined to the adrenal gland. So just we'll talk about adrenal tumors which are confined to the adrenocortical carcinomas. The management is like this: aim for complete resection. If it is R0 resection, and the low risk tumors, low risk is, as we say, NSAID stage 1 to 2 and Ki-67 staining less than 10%. You can follow them, or you can consider mitoten adjuvant. If it is a high risk tumors, high risk are Ki-67 staining more than 10%, and stage 3 and stage 4 tumors. In these tumors, after complete resection also, even after R0 resection, you give adjuvant mitoten. We'll come to it later on. So for incomplete resection, we have to definitely give adjuvant treatment either in the form of radiation or radio and chemotherapy. And how do we follow them? Follow up with every 3 months, imaging and tumor markers. If they are tumor-free, follow. If there is a recurrence, again, you have to see when did the recurrence occur. If the disease-free interval is more than 12 months, you operate them. If the recurrence is less than 6 months, we again go for adjuvant treatment in the form of chemo or radiation. Now coming to having learned about the localized tumors, locally advanced and metastatic disease, how are they managed? So metastatic and locally advanced tumors. In most patients, The first line therapy is chemotherapy. The drug of choice is mitotane. Mitotane can be given alone or in combination with other therapy. So the EDPM, which is called etoposide, doxorubicin, cisplatin, along with mitomycin, is the first line treatment of choice for metastatic or very advanced disease. In selected patients who have got low tumor burden and maybe 1 or 2 sites of metastasis, mitotane monotherapy is reasonable. So surgery with the local regional therapy should be adopted in addition to systemic therapy in selected patients. Surgery is a treatment only if all the tumor in the primary along with the metastasis can be removed, then only you should contemplate for surgery. So there are so many local therapies like cryo, microwave ablation, chemoembolization can be tried because they have got varying results and the treatment is individualized in each patient. So coming to again role of debulking, that is the primary and debulking metastasectomy. Only if you are able to remove 90% of the disease burden, then only you attempt. Otherwise, no role for debulking metastasectomy. What is the rationale? Here you are aiming to alleviate the tumor-related side effects and you are facilitating the additional systemic therapies. So this is the flow chart for advanced disease. So as I said, what is the role of debulking surgery? Only when you can remove at least 90% of the disease burden. If the patient has already received prior systemic therapy, again the role for again systemic therapy. No prior systemic therapy, you give mitotane, or the advanced disease mitotane plus EDP. Recurrence during adjuvant therapy, mitotane plus local therapies. So you follow them up. If the tumor is stable, you operate them. Otherwise, the progressive disease, again, you give mitotane plus EDP. Progressive disease, consider additional therapy and inclusion in the clinical trials. Basically, in metastatic disease, try to debulk if possible. Otherwise, give adjuvant therapy and see that the disease regresses in size, then you can contemplate surgery. So what are all the systemic therapies? We are talking about systemic therapy. So as I said, mitotane, chemotherapy, mitotane plus streptozotocin, and mitotane with etoposide, doxorubicin, cisplatin can be given. And there is another role, drug therapy, where we give drugs to control the symptoms secondary to the hypersecretion. So one drug therapy is chemotherapy. The second drug therapy is you give drugs like ketoconazole, aminoglutamide, mitoperone to counteract the effects of the hormones. The other emerging therapies are targeted therapy, immunotherapy, and IGF-1 inhibitors. So mitotane therapy. What is mitotane? Mitotane is a synthetic derivative of insecticide DDT. It is the most commonly used chemotherapy in adrenocortical carcinoma. The mechanism of action is it has got a direct cytotoxicity in the adrenal cortex. It has also got oxidative damage, and it also inhibits the enzymes involved in steroid synthesis. So it has got a threefold action. The dose is, you have to start at 1 gram twice daily, and the dose is increased every 4 to 7 days by 0.5 to 1 gram per day until the maximum dose of 5 to 7 gram per day is reached. This chemotherapy goes for a long time, even up to 2 years. So it's very important to monitor the blood levels. The blood levels should be around 14 to 20 milligram per liter. If the patient has got side effects, you monitor the blood levels, and if the blood levels are high, you decrease the dose or stop the drug for some time. So the mitotane can cause variety of side effects. The common side effects are GI side effects, like nausea, vomiting, diarrhea. It also affects the liver, so it alters the liver enzyme and increase of the liver enzymes. It also causes drug-induced hepatitis. When these are present, you give supportive therapy, and if they're going beyond hand, the enzymes are increasing very fast, you have to stop, give a drug-free period. And it also affects central nervous system in the form of ataxia, balance disorders, decreased memory, and endocrine system. As I said, the drug affects the enzymes. It acts on the adrenal cortex. So the patient can go into adrenal insufficiency, hypogonadism, hypothyroidism, gynecomastia. Because it affects the first enzyme, the cholesterol synthetic pathway. So if the cholesterol doesn't go through the down pathway, there's the excess of cholesterol called hypercholesterolemia, skin rash. So these are all the various side effects of mitotane: GIT, central nervous system; endocrine, that is adrenal insufficiency; hypercholesterolemia, skin rash. So you have to remember all these side effects. So when the patient is on mitotane therapy, you have to do certain lab tests at regular intervals. So you have to monitor the blood levels of mitotane every 3 months. And every 3 months, you should do a blood count, LFT, cholestatic liver parameters, thyroid profile, cholesterol levels, and other hormone levels. So the next chemotherapy is combination chemotherapy. Either, as I said, either you can give mitoten alone in a low burden disease. High burden disease, you have to combine mitoten with other chemotherapy agents like etoposide, doxorubicin, and cisplatin. This is the one trial which has shown that the combination chemotherapy is superior in advanced disease. This trial is called FIRM-ACT trial, first international randomized trial in locally advanced and metastatic adenocortical carcinoma, where they have compared mitoten plus streptozotocin versus mitoten plus EDP. Though the overall survival was similar, the mitoten EDP group had a better objective response and progression-free survival. So MEDP is a first-line regimen of choice in patients requiring systemic chemotherapy in advanced or high burden disease. Now coming to radiation, what is the role of radiotherapy? Radiotherapy is the treatment of choice for patients who have got bone and brain metastases. Adjuvant radiation can be given when there is a R plus resection, where there is some residual disease, R1 resection. So it is basically adjuvant radiation is given to decrease the local recurrence after surgical resection. See here you can see after adjuvant radiation, the local recurrence is significantly less compared to patient who has not received adjuvant radiation, 14% versus almost 80%. So radiation is strongly considered in patients who have got positive or indeterminate surgical margins. Now coming to targeted therapy. So targeted therapy role is not much when compared to other tumors like RCC, because in most of the studies, targeted therapy is given after the patients were treated with mitoten. So the targeted therapy is given in patients who are heavily pre-treated with mitoten or combination with mitoten or with EDP. So none of the studies has so far shown definitive effectiveness. Of course, there are some studies. Most data for targeted therapy exists for IGF-1 receptor antagonist, that is fitillimumab, a fully monoclonal human monoclonal antibody which acts against IGF-1 receptor. There is another IGF-1 receptor antagonist called sixtutumab. So these are the various agents which have been tried, targeted agents, and there are the different studies like sunitinib, sorafenib, which are used in renal malignancy. They are also used here. Bevacizumab, which is VEGF inhibitor, VEGF antibody, these are also used here. And sorafenib, sunitinib, erlotinib, temsirol, that mTOR inhibitors are also used. All the agents, targeted therapy agents, which are used in renal malignancies are tried in adrenal malignancies. And the immunotherapy is also tried. They like our pembrolizumab, the PD-1, PD-L1 inhibitors. Immunotherapy is also tried in adrenal tumors too. The results are not so great. What is the role of targeted radionuclide therapy? The IMTO treatment, in one study where they have shown that the progression-free survival was significantly better in patients who received targeted radionuclide therapy. So we have now discussed systemic therapy for the agents which are used to decrease the tumor burden or control the tumor. As I said, there are agents which are used to control the hormones excess. So when the patient has got hypercortisolism, you can give mitotenon. Mitotenon works to decrease the tumor burden. As I said, it also works on adrenal cortex, inhibits the enzyme. So it decreases adrenal cortisol levels also. Hypercortisolism, you can give mitoten, you can give mifepristone, miterapone, ketoconazole, etomidate. Mineralocorticoid excess, you can give spironolactone, eplerenone, and when the patient is called hyperandrogenemia, we give spironolactone, and estrogen excess, we give aromatase inhibitors and tamoxifen. So these are the drugs which are given to decrease the effects of the hormone excess. So coming to prognostic factors, what are the poor prognostic factors in adrenal cortical carcinoma? Large tumors, high stage, tumors which are hormone secreting, incomplete tumor excision, older age group, presence of necrosis, high mitotic rate, lymphovascular invasion, and high B score. These are the poor prognostic factors. So what is the 5-year survival rate compared to the stage-wise? Stage 1 tumors have got a better 5-year survival, nearly 60%. Stage 2 tumors have got 58% 5-year survival. Stage 3, 24%. And stage 4, there is no 5-year survival. So this is one study where they have further modified the NSAID classification. They were modified. So they have subdivided stage 4 into 4A, 4B, 4C. 4A is two metastatic or distant metastatic organs. 3 is 3 metastatic, and B is 3 metastatic organs. 4C is more than 3 metastatic organs. This is called modified NSAID classification. They have also taken other parameters like grade, R status, that is resection status, age of the patient and symptoms, and they have grouped the parameters as GRAS parameters. So in that study, they said that modified NSAT classification and GRAS parameters, they help best to stratify the prognosis of the patient with advanced adrenocortical carcinomas. So now, having learned about the treatment, everything, how do you follow up these patients after surgery? Follow-up is by imaging and biochemical evaluation. So we have to do hormonal marker, like in our case, because androgens were elevated, we have to do these androgen dehydroepiandrosterone and every 3 months. And imaging, CT is the best mode of imaging. CT every 3 monthly, CT abdomen and chest for 2 years. After 2 years, the frequency of the imaging can come down, maybe every 6 monthly or every year. Coming to our case, this patient has been followed up till now and is doing well. We have done CT. There is no recurrence in this patient. In fact, before our class, I spoke to him a few days ago, and he's doing extremely well. And the CT was done 3 times, and CT doesn't show any recurrence. Well, this is just to summarize what I've told, how to manage stage 1, 2, 3, stage 4. Surgical, if the tumor is resectable, resect completely. If it is not resectable, downstage by giving adjuvant, neoadjuvant like mitoten, and then you consider resection. Last few slides about adrenocortical carcinoma in children. It's a very rare malignancy in children, constitutes about 0.2% of childhood cancers. There is some variation in the clinical presentation. So the visualization is common clinical presentation in children compared to adults, because adults, Cushing syndrome is a common presentation. And the tumors are common in female children. And if we take the age group of 13 to 20 years, it is predominantly seen in females. There's a little difference in the staging system compared to adults. The staging system described for pediatric adrenocortical carcinomas are like this. Stage 1 is tumor totally excised, volume less than 220 centimeters, 200 centimeter cube, sorry, not tumor volume, absence of metastasis, or normal hormone levels after surgery. This is the staging after surgery, pathological staging. Stage 2 is microscopic residual disease, volume more than 200 centimeter cube, tumor spillage during surgery, or persistence of the abnormal hormone levels after surgery. Stage 3 is gross residual or inoperable tumor. Stage 4 is distant metastasis. So this staging is different from the NSAT staging or UICC staging, what we discussed for adults with adrenocortical carcinomas. So coming to the prognostic factors in children, again, they're almost same. The early stage or low stage tumors have got good prognosis. Virilization is a good prognostic factor. And younger age group, less than 4 years, have got a good prognosis compared to incomplete tumor excision, capsular rupture, and venous involvement. They come into bad prognostic category. So now to summarize whatever I've said in the last 40 minutes, adrenocortical carcinomas are rare tumors. They must be considered in the differential diagnosis of all adrenal tumors which are more than 6 centimeters. Evaluation of functional status, even though the patient doesn't have any symptoms of cortisol excess or mineralocorticoid excess or androgen excess, evaluation of functional status is a must. How do you evaluate? As I said, you have to evaluate for cortisol secretion, catecholamine secretion, mineralocorticoid or sex steroids. Evaluation of functional status is a must. Complete surgical excision should be aimed whenever possible. And adjuvant therapy in the form of mitoten or mitoten EDP is considered in most patients. Newer therapies like immunotherapy and targeted therapy have been tried, though the results are not that encouraging. And prognosis-wise, if you diagnose at the early stage, prognosis is good, but most of these tumors are diagnosed at a later stage, and hence the prognosis is poor. So because there are not much has changed in the last 5-10 years in this field, so the patient should be encouraged to enroll in clinical trials, so to see for newer modalities therapy and how these new therapies work. So that's my presentation. Then I conclude. Thank you. Thank you for your patient listening. Now I'm ready to take any cases if you have any.
Surya Prakash.
Yes, sir.
I think there is only one question in the chat box, which probably you have addressed during your evaluation. This question is from Surjit. What is the cause of rapid washout of contrast in adrenal adenoma? Usually in malignancy, there is enhancement and washout because of increased vascularity. But here in benign adenoma, enhancement and rapid washout.
So
He wants to know the principle of washout.
So they are lipid-rich tumors, adenomas. So there's not much of vascularity. Whereas if you take of malignancies, you find neovascularity and pooling of contrast will be there. There is some neovasculature, sinusoids will be there. That is the reason for persistence of the contrast in malignancies. In adenomas, because of presence of lipid and not much of vascularity, whatever contrast comes, it just goes out. Most of the tumor is occupied with the lipid rather than the vasculature. That could be the reason. Maybe would you like to add anything, sir? Arun, sir?
No, that's fine. Absolutely fine. Another question was regarding one of the differential diagnoses, schwannoma, renal parenchymal schwannoma.
That's a rare possibility. Again, many tumors arise from parenchyma. Adrenal schwannoma, that's called ganglion neuroma, is one of the differential entertained already.
And what I think is students are frequently asked in the exam, especially if you have a mass in that area, differential diagnosis between the adrenal mass, the retroperitoneal mass, and the upper pole renal mass. Yes. So that is a common question which usually asked. And number two, if they are in the early part of the exams, if the mass is palpable, again they are asked whether it is a retroperitoneal or whether it is an intra-abdominal, intraperitoneal mass. And these are the sort of questions which usually the examiners are fond of. You would like to say anything on that?
Yeah. In this case, though it's adrenal mass, it has all the features of renal mass. It was a big, huge mass. It was bimanually palpable. We cannot rule out renal mass based on clinical examination. So in exam, sometimes they ask if the mass is huge mass touching both the anterior and posterior abdominal wall. Such masses are bimanually palpable, but not bellotable. So for a mass to bellot, there should be some space between the mass and the abdominal wall. So this is a commonly asked question. All masses which are bellotable or bimanually palpable. But all masses which are bimanually palpable are not bellotable because huge mass which is abutting both the abdominal walls, anterior and posterior abdominal wall, may not be bellotable. This is one practical question which you can ask.
Yeah, that's very, very common question which is asked. Yeah. Sitaram and Rajesh, if you have any questions or any other questions, you can put quickly in the chat box. Dr. Rajiv Sood, are you there?
Is there any role of MIBG scan, sir?
No.
MIBG.
MIBG is specific for adrenal medullary origin tumors. So in adrenal carcinomas, MIBG doesn't have much role.
I think I'll just get Dr. Rajiv Sood online before we propose a vote of thanks. Dr. Rajiv Sood?
He is muted.
Yeah, I'll just see whether I can get him.
Okay.
But it was a very, very comprehensive and very extensive. I think some part of the adrenal cancer would have easily covered the adrenal masses in general. So I think the evaluation covered not only the cancer, but actually the adrenal mass. It was so comprehensive. And 1 minute. Hello, sir. Can you come, sir? For just we are done with the class. So and if you see the management is not only the surgical, the medical oncology management has also been completely covered with the mechanism of action and the adverse effect of all the drugs. So probably it is worth just going in again when you are reading the adrenal, especially when you are reading the adrenal adenomas and pheochromocytomas. Just go back again to the archives, revise this because this is very extensively, beautifully covered. So it will be worth going back again when you are revising the adrenal. Very, very, very thorough class on adrenal cancer.
I can share this presentation if somebody wants.
No, sir. This will be there in the archive, sir.
Okay. Recorded. Okay.
Yes, sir. Yes, sir. So, Dr. Surya Prakash, it was very, very nice. Before we leave, I'll just request Dr. Rajiv to propose a vote of thanks, and then we'll say goodbye. And okay, over to you, sir.
So I think this was wonderful session, and this was the interactions were really very good, and Surya Prakash, as usual, has done the job very well. And as far as archiving these lectures, it is very important for us. And many residents are directly benefited today, and many more will be benefited for future. And such interactions will continue. Indian School of Urology is committed for this distant learning, virtual lessons, or whatever you call it. We started calling it as the this Euromat virtual classes, but now distant learning or whatever new words have come, that is the nomenclature only. And we are going to have more and more sessions, and you motivate your teachers also, all the residents who are there, so that they are also interacting in the future. And ultimately, this will become the way of learning for future and way of learning for the Indian urologist. I congratulate Dr. Surya Prakash, Dr. Arun Chawla, and both the residents, Dr. Rajesh and Dr. Sitaram, who has done wonderful job while they were working, and from their duties, from that environment, they are directly having this learning. This is another aspect, that even on your duty, even in your leisure time, after your busy schedule, you can connect to such lessons, and through that to the eminent faculty of national fame. Thank you very much for all to join. Back to Dr. Arun Chawla.
Thank you, sir. Thank you. With this, we'll wind up again from all the agents, and on personal point of view, thanks, heartfelt thanks to Surya Prakash for sparing his time and giving a very, very elaborate and very comprehensive coverage of. Actually, if you see the book, it looks a very small topic, but the way you have covered, it looks like it's a very big topic. Why? Because everything has been covered very, very in depth. So thank you, Suraj. Thank you once again, and thanks all the agents. Thanks, Navneet. Thanks, Kiran. Goodbye. Stay safe. Stay well, sir.
Thank you, sir. Thank you, Rajesh, sir.
Yeah. Okay. Thank you. Bye.
Bye, sir.
See you in the next.